and thank you for joining us today. I'm really happy to have everyone here. My name is John Baton. I am a two-time kidney transplant recipient who has experienced every modality of treatment that there is. I am also the winner of or I should say, the awardee of the 2023 American Kidney Fund Hero of Hope Award. I'm a resident of the District of Columbia, and I just recently celebrated my my 5-year kidney anniversary, February 27th. So I have a lot to celebrate these days. I am a PR and marketing professional who dedicates a lot of time in the advocacy and consulting arena for kidney health issues. And I again want to welcome everyone here today and hope we find this session to be very insightful and educational. Today's topic is an approach to care beyond in-center dialysis, dialysis options at home. Our goal today is you will learn about the different home dialysis options that exist. Although there are benefits to doing dialysis at home, research shows there are disparities in Black and Latino patients being presented with home dialysis as options. We will discuss home dialysis, barriers, disparities, and steps to take for improved home dialysis education from both a patient and provider perspective. As we get started, I wanted to encourage everyone joining to type your questions into the chat box. We will try our best to get to all your questions during the segment at the end of this talk. I'd like to take this moment now to sort of introduce our panelists. Our first panelist for today is Dr. Lauren McDonald, has been a nephrology practice in Dallas with Dallas Nephrology Associates for over 30 years. She has received numerous accolades for her commitment to the nephrology profession. Dr. McDonald is a member of Links Incorporated, Mid-Cities chapter, a sustaining member of the Junior League of Dallas, a member of Leadership Dallas, and a new member of the Dallas Assembly. She currently is the chairwoman of the Parkland Board of Managers for Parkland Memorial Hospital, Dallas, Texas. We also have joining us today, Dr. Megha Salani, is an assistant professor for medicine at Vanderbilt University Medical Center and member of the Division of Nephrology. She joined Vanderbilt as faculty in 2018 as a clinician educator. As the medical director of Vanderbilt Home Dialysis Clinic, Salani has worked to expand home dialysis access by streamlining dialysis education and is working to create a smoother transition from chronic kidney disease to end-stage kidney disease. So I would like to start the conversation with Dr. McDonald. Dr. McDonald, I remember when I first began exploring home dialysis, there was very little information presented to me until one day my nephrologist walked into the center and kind of said, "Why are you sitting in this chair in the center?" and mentioned to me home dialysis. And that was literally the beginning of my home dialysis journey. Can you walk us through the different home dialysis options and talk about some of the major differences between home and in-center dialysis?
Sure. And I'd like to just welcome everybody to Kidney Action Week. And thank you, John, for moderating. Well, home dialysis is something that kind of came about many years ago, mostly in Canada. And we found that patients on home dialysis do very well. And briefly, because I'll have more remarks later on, or there we go, my slides are up. But there's home hemodialysis versus in-center dialysis. Now, also when you think about home dialysis, besides home hemo, there's also peritoneal dialysis. Now with home dialysis, either modality, there's training that's required. We'd like our patients to have the support of family and friends. The great thing about home dialysis is it gives you independence and you're able to take charge of your treatment. And I think when people have chronic illness, it's very important for them to be able to take charge. Now, as opposed to in-center, you have a set schedule. It's almost like an airplane reservation. Monday, Wednesday, Friday at 5:30 a.m. You have a very social atmosphere, which some of my patients, particularly a lot of my senior citizen patients, really enjoy. They enjoy getting out of the house, seeing the same people several times a week. There's one thing, though, there's a lack of privacy. And as the doctor and the team rounds, We ask questions, and it's not a super private atmosphere. And everything pretty much is done for you. You're weighed, your needles are inserted, the information on the machine is captured. And some people prefer to have everything done for them as opposed to taking charge themselves. May I have the next slide, please? Now, just home dialysis options. You see home dialysis and the dialysis machine there. You see, just like in center, the blood is taken out of the patient, go through the dialyzer, through the machine, and return to the patient. With peritoneal dialysis, believe it or not, the gut is almost like a membrane that can selectively remove what we don't need and keep what we need, and that's peritoneal dialysis. Next slide, please. With home hemodialysis, cleanliness is mandatory. And I say this because it's something that a lot of us take for granted. I've had patients that had like 10 cats. You can't really have that in your room where you do dialysis. Sometimes little children can kind of pick at things and introduce infection. So cleanliness is very important. Most places for home hemodialysis, there's a 6-week one-on-one training program with a nurse. We like the patients to have a fistula, which remember, it's a connection between the artery and the vein in your arm, but we do use perm caths in some situations. The prescription for home hemo is flexible. I have patients, for instance, that work, they come home, they may have kids that have basketball, soccer practice, whatever. So they may dialyze 4 hours one day, 3 hours the next day. But that prescription is something that's discussed between them and their nephrologist. Before you do home hemodialysis, we evaluate your home space. We want to make sure there's enough space for your supplies, your electricity is working well, and your water is of the purity that's needed. You see on the slide there, that's the Tableau machine. And Tableau is used in home dialysis and in some places in acute dialysis. What's convenient about it is that it's small. As you can see, it's about the size of a nightstand. And when you set up your tubing, it's kind of a one little set that you push in. And then the Tableau machine connects to your regular 110 volt electricity socket at home. Next slide, please. With peritoneal dialysis, cleanliness is also very important. We teach the patients using gloves and a mask. You have usually it's a 7 to 10 day training period one-on-one with a nurse. During that time period, patients are taught how to check their blood pressures, weigh themselves, make certain judgments about the strength of the solutions that they're using. The stronger solution, generally the more fluid is removed. Now, in some cases, we can use the PD catheter sometimes 2 weeks, sometimes sooner after insertion, but ideally we like to wait longer. There's something that we'll talk about later on called urgent start, where we use the catheter and start the treatments pretty quickly. Again, the nurses and techs will go to the home. Peritoneal dialysis sometimes requires a lot of space for the boxes for the different exchanges. And it's important to remember that diet is very important because patients will lose a small amount of protein with each peritoneal exchange. And on the slide there, you see a picture of the cycler machine where the solutions are placed on top and they're warmed, and then tubing comes from the machine to the patient. And of course, exchanges are done throughout the night. And then in the morning, when the patient is finished, they cap off and go about their business to work, to school, or whatever they have to do. Next slide, please. Now, that being said, and as John mentioned, home dialysis is a great option. I think because it gives patients that independence, that ability to take charge, the flexibility, particularly if you have a family. But there's disparities, unfortunately, in home dialysis. African Americans compose about 15% of the population, but about a third of the end-stage renal disease patients. When we look at the renal data survey from 2020, all of the end-stage patients, of all of them, only 7% of the home patients, that is, are Black or Latinx, whereas 9% are white patients. Predominantly Black and Latina zip codes have far less utilization of home dialysis. Next slide. There's a great little article written in the American Journal of Managed Care by Doctors Wang and Zappel from 2023. It was a retrospective study. It went from 2006 to 2016, and there were greater than 1 million patients in this retrospective study. The number of home facilities in that study increased from 16 to 22. And when we looked at the white patients, they increased from 20 to 26%. However, non-white patients only increased from 13 to 18%. So you might say, well, with these facilities increasing, how come there's such a disparity? Next slide, please. Why do these barriers exist? There are many, many reasons, and I know we'll hear more about that with Dr. Solani later on. But for one thing, sometimes patients, and we call them social determinants of health. People sometimes have small housing, not enough space. We had an informal conversation in the major cities in the country. Rents are so high, it's hard to have enough space, especially if you're on dialysis and you also have a family. Housing can be unstable, again, because prices are so high. Interest rates, if you're thinking about buying a home, are the highest they've been in a long time. And as a result, there's lack of money for outpatient expenses. There's also lack of a timely referral. That's so important. For instance, if you're seeing a primary care doctor and there's a delay in finding out that you have chronic kidney disease that may lead to the need for dialysis and or transplant, that can be a problem. And not to mention just physically having to go on dialysis in a very quick way, the emotional adjustment to becoming a dialysis patient is just very, very large, very difficult when you're not informed about your disease. There's lots of misinformation. I was at a health fair this weekend. It was amazing to me the people that came up and the things that they were saying about dialysis and transplant. There's a lack of bilingual training, and there's an immigrant-related bias, mostly to do with the bilingual or the need for translation in their native language. I also found in the last 30 years I've been doing this, a provider bias. I trained in Dallas, Texas, and also in Philadelphia, two large cities. But sometimes you meet nephrologists that really haven't had much training in home dialysis, or they have preconceived ideas of who should be on home dialysis. Next slide, please. So what can we do as healthcare professionals? First of all, we've got to be able to provide education and information. And I always like to use the phrase, I quote Joe Madison, who's a journalist who just passed away recently, put it where the goats can get it. In other words, if you're trying to tell somebody something, make it simple. And I don't care if this person has an 8th grade education or a PhD. Make it simple so people can grasp it, and then you can fill in more information. In some countries throughout the world, they have what they call a common house where patients can go for their daily home dialysis. In this country, usually with Medicare, with dialysis, it's a home program. So there's not really reimbursement for someone to come into your home and do this for you. In other countries, particularly New Zealand and Canada, they take a different approach, which makes it more user-friendly. I mentioned urgent start. So if someone rolls into the hospital, they need dialysis, we can go ahead and start them on, for instance, we do peritoneal dialysis. They come into our facility, and at the same time they're learning about dialysis, they're getting their dialysis. It's kind of killing two birds in one stone. We also can do televisits, and I know in the state of Texas, there's various rules about this that are sometimes rather cumbersome, but I know that I have no trouble doing a televisit for my patient if that's what's easiest for them at that time. Now, we can talk about home dialysis, peritoneal, home hemo, barriers, but the bottom line is dialysis is something that's emotionally very difficult for the patient and their family members. So it's really important that we address mental health. And in this country, especially in some states in this country, mental health just really lags behind. But it's very important to look at the entire patient, besides the fact they have kidney failure and they need dialysis. Are they depressed? Are they anxious? Do they have early dementia, which kind of impedes the ability for them to learn? So we need to look at all of this completely. So anyway, we talked about home dialysis, health disparities, decision-making, and telemedicine. I'll turn it back over to John.
Donald, Dr. McDonald, that was very insightful. And it also just reminded me a lot of what I had to do in considering peritoneal as well as home hemodialysis. I've been fortunate enough to have experienced both. But as you were talking, there were some questions that I think may be helpful for the audience. So I wanted to ask, one of the questions I wanted to ask you is that when I was transitioning to home dialysis, I found that my trainers and my team to be very, very helpful and in moving me in that direction, and including my nephrologist. As a medical provider, what advice would you give to other medical providers as they assist their patients in their home dialysis journey?
The first thing I'd like to say is we all, doctors, nurses, patients, everybody has biases. So it's very important when you approach a patient to try to remove your own individual biases. That because someone may speak a different language, they seem kind of slow, just take away the biases and give somebody a chance. I've always been so pleasantly surprised when, I think, well, I don't know if he's going to do well. And most of the time, that turns out to be the best patient. So it reminds me all the time to remove the biases that I have approaching a situation. And what I like about dialysis is that when we make rounds, besides being the nephrologist, we have the nurse, we have the dietitian, we have the social worker. Patients will communicate in different ways with each member of the team. So it's nice when we have a team meeting and to hear everybody's opinion. So it really helps to get that joint opinion in approaching patients and their different issues.
Another question that I have is you share different types of home dialysis that dialysis options is available. One method, can you share maybe one method that's more commonly used?
That's a great little question. I tell you, I've been fortunate enough to travel all over the world. And, some countries look at home dialysis at a greater rate than we do in this country. And also, different regions of the country embrace dialysis a little bit more than other regions of the country. So I can't say that there's a favorite type. A lot of times it's a regional bias. For instance, I've had patients that have been in very rural areas in Texas or in the bordering states of Oklahoma and Arkansas. And so home dialysis, peritoneal was ideal for them. The other thing that's nice about peritoneal, they get their labs checked and they see the doctor once a month. So traveling back and forth, some patients are traveling over 100 miles. It makes it a little bit easier. And even with home hemodialysis, when it started in Canada, originally, it was way out in the rural areas, and they were connected with nephrologists in the larger cities. So it really kind of depends on where you are and your situation particularly.
So, as patients prepare to move to home dialysis, can you review some of the key points that they should keep at the forefront of their mind as they're trying to make this decision?
Well, first of all, a lot of times when I talk to patients, hey, what about home dialysis? They've heard maybe some misinformation and they think, it's too complicated. I could never do it. And the analogy I always make is it reminds me of like when you're learning to drive a car. When you're 15 or 16 years old, you're thinking about all the things you have to do. And then now, after driving for a year or two or more, you don't even think about these things. They go naturally. So I think it's important to tell people, hey, like I said earlier, put it where the goats can get it. It sounds complicated, but really you are able to master this situation. A lot of times I'll say to people, you gave birth to a child. That's not an easy thing. You fix dinner every day. You send him to school. You put him in bed. I mean, those things are not easy. So I try to remind people there are many things that you do in day-to-day life that seem complicated, and dialysis seems complicated, but it's achievable.
Thank you so much for that. I do have one other question that came up while I was listening to you. I know that you were talking about, fistula access and PD catheter. Are there surgeries involved? What type of procedure is required for getting those items?
Great question. First of all, for a fistula for hemodialysis, I like to refer my patients sometimes as early as 3 months because the fistula is a surgical connection between the artery and the vein. And over time, the pressure is transmitted from the artery to the vein, and you have something under the skin. I always tell patients it looks like a big worm. So it takes time for that fistula to what we say mature so it can be easily used without any damage. And some patients take longer than others, so I like to give a long period of time. Now, in Dallas, usually we do this with day surgery. The patients go in, the surgery takes very little time. Depending on the patient's risk factors, sometimes they do not even use general anesthesia. So that's a fistula. And for most hemodialysis, we like a fistula. However, for some home hemo programs, they will also take permanent catheters. In contrast to peritoneal dialysis, again, that's inserted to either side of the belly button, tunneled down into the true pelvis. That again is a day surgery, takes a very short period of time. And once it's accomplished, we like it to stay in place, ideally maybe 4 to 6 weeks. Sometimes we'll have our nurses flush the catheter to make sure it's
Mhm.
functional. But if the patient needs dialysis quickly, sometimes we can start using it as early as 2 weeks, and we call that urgent start.
Okay. So, and I know that I said one last question before, but another question has actually come to mind, and that is with regard to learning how to do peritoneal and or home hemodialysis. What is the training period like? I mean, how much time does it take? Do people need to take time off from work or take sick leave? What are some of the things that they may need to consider? And again, how long does it take to train?
Well, I'll start with home hemodialysis. Generally, it's about a 6 week training program. And it sounds like a lot, but we want patients to be completely comfortable by the time they finish the training. They have to learn how to clean the arm, place the needles, set up the machine, and to be able to do this reliably. Now, sometimes if patients work, depending on the unit that we're in, we'll have the patients trained after their work hours, sometimes in the evening, if that's what works, and we can get nurses to do that. We like the patients to bring a family member or a friend. Now, it's not realistic to think that that friend person will be there for every minute of the 6 weeks, but we'll have them come at certain times so they're able to support the patient and understand what the patient is going through. Our social workers work with them, so if they need to take family leave or sick leave, whatever, we try to make it happen. And that's home hemodialysis. Now, with peritoneal dialysis, the training time is 7 to 10 days, one on one. It's a little bit shorter. And again, we try to be flexible. If the patient is working, if they need family leave or whatever, we try to be flexible to make it work for the patient. I hope that answers the question.
I think it does. I remember my training very well and how supported I was during that time. One last question. I'm not going to say that anymore. I'm just going to ask you another question. So I wanted to ask you, sort of, how do you encourage patients to maintain mental separation of home as a space of sanctuary with a dialysis space at home? I know for myself, this was something that I had to navigate because my home is my home, but it was also my treatment center too.
That's an excellent question. And I think a lot of times as a provider, we don't really think about that. But all of us, dialysis and non dialysis patients, our home is our sanctuary. And many of us will have a special room or a place, sometimes as simple as a special pillow or a blanket. So, depending on the layout of the patient's house, a lot of times if they're able to have a room that they can dedicate just to dialysis, we like to do that, particularly for home hemo. So we see if there's a room. If they're not able to have a room, then maybe particular spot in the room where they can put, maybe their favorite chair, their blanket, things close by to give them, first of all, comfort during dialysis, but to mentally separate their dialysis time from their other home time. Now, John, as we go forward with this, and particularly in this day and age, as I mentioned, with housing costs so high, first of all, in our city and other cities, we got to make sure somebody has a home. We've
Mhm.
had patients living in storage facilities. And of course, that's not ideal for home hemo. So that's an excellent question. That's something that needs to come up where patients can have a feeling of solitude when they do their dialysis and comfort, but also make that separate from the rest of the home. That's a great question.
Okay. Dr. McDonald, I wish we could go on for more and more because I know I have more questions, and it's taking me back to a time when I was making these very same decisions and beginning my home dialysis journey. But I think we should turn to Dr. Solani now and get some of her presentation and talk to her. So, but before then, I actually want to encourage everyone joining to type your questions into the chat box. We definitely would love to hear from you, any questions or comments that you may have. And we will address all these questions towards the end of the segment here. Dr. Solani, thank you so much for joining us today. Dr. McDonald shared information on health disparities. Could you elaborate further on the health disparities, barriers, and solutions that exist to combat said barriers?
Absolutely. Thank you. So, as you mentioned, I'm going to be discussing health disparities in home dialysis, what the potential barriers to doing dialysis at home may be, and possible ways to get around that. I also want to talk about the informed decision-making process and how to advocate for yourself to ensure that you know all of your options, either before starting dialysis or while on dialysis. And we'll also talk a bit more about the use of telemedicine for home dialysis. So as Dr. McDonald mentioned, there is an increased risk of kidney failure in the Latin American population. That risk is 1.3 times their white counterparts, and for Black Americans, it's 3.4 times. However, the use of home dialysis is less than 7.5% of those patients needing dialysis, compared to 9.3% of white Americans. When we look at comorbidities or geographical locations, that disparity continues to exist. And part of that is related to socioeconomic factors, systemic factors, and health conditions. One of the biggest challenges we have with expanding home dialysis is unstable housing or inability to have communication between the patient dialyzing at home and the dialysis unit. So it's very important for the safety of the patient that they're able to contact someone if they're having any difficulty, because there's not a tech or a nurse at the house doing the dialysis. They do need to have phone connection. The dialysis equipment is typically set up with internet, so Wi-Fi access, so that the information can be communicated to the dialysis unit in real time. If internet is not available, it can still be logged and communicated at a later time, as long as there's some way to communicate. And of course, if there's not a area to keep the equipment, if somebody is having to go from home to home, it can be difficult for them to do dialysis at that time. However, it's important to know that that is the barrier of maybe why that's not being offered, so that if housing becomes stable later, this could be reassessed. For home dialysis, we do want electricity generally, but there are ways to get around that. So if there are issues with occasional power outages for patients on home hemodialysis, there is a backup power that will allow the dialysis machine to run long enough to to rinse back the blood, so that you don't have an issue until the electricity is running again and get started again. For peritoneal dialysis, there is the cycler, but there are also manual exchanges that are just using gravity to allow the fluid to go into the abdomen and out. And that can be done without electricity. For hemodialysis, running water is important to make the dialysate that's going to be used for the treatment. There are some machines that have bags that can be used when running water is not available. For peritoneal dialysis, the bags are there, so you don't need water to make the dialysis fluid, but We do want clean water to clean our hands and to clean the area where the catheter is coming out of the abdomen. And so sometimes patients don't have access to running water for a period of time and need to get distilled water from the store or come up with something that can be done temporarily while that's an issue. As far as lack of space goes, oh, hello. Okay. With regard to space, the peritoneal dialysis does require several boxes of equipment and bags to be sent to the house. However, if someone has limited space, that could be sent more frequently so that there's not as much at one time. Whereas in-center hemodialysis is typically close to the patient's house, for home dialysis, the transportation may be a lot further away, and it may be difficult to set up public transportation or an access ride back and forth from the unit. So although the visits are only once a month as opposed to 3 times a week, transportation could still be a potential barrier. For patients that are on home hemodialysis, they may send their labs and inject their medications at home. And then we'll talk about telemedicine as an option. Peritoneal dialysis patients do need to come to a unit to have labs and medications. However, if they are close to a unit within that practice that's not a home unit, but that can get labs, that may help alleviate the long distances needed to be traveled. Patients that are uninsured or underinsured may have difficulty getting access to home dialysis or to be able to afford the extra costs. And then home dialysis is generally 4 to 6 times or 7 times a week, depending on the modality. And so it can be quite a time commitment, and that effort is done either by the patient or their care partner or together. But it does put the burden of the care on the patient and their loved ones. Next slide. The systemic factors that can be a barrier to home dialysis include lack of pre-dialysis nephrology care. Kidney disease does not cause symptoms generally until the kidney disease is very severe. And so sometimes people don't know they have kidney failure until they're needing to start dialysis very soon. And in that situation, they may not have had any education about what the options are. If they're needing dialysis quickly, the fastest way that can often be arranged is through a dialysis catheter and hemodialysis. And oftentimes they're set up with an in-center unit and haven't had a chance to talk to anyone about home dialysis. It is possible to go from in-center to home dialysis, so that discussion could happen later, but it's easier to fall through the cracks in that situation. Language barriers can also play a role. There are generally going to be interpreters that can help to educate the patient prior to starting home dialysis and while they're doing home dialysis. However, this process can take longer, and if that time is not spent ahead of time, it may cause a lack of education. Not all nephrologists are comfortable with home dialysis, and if they have a lower comfort level, they may not offer it to someone who has a more complex medical history, or if they feel like they're at risk for complications that they don't know how to address. And then providers may have implicit biases that skew their perception of who is a good candidate just based off of things that may not actually influence their ability to do dialysis at home. And then certain health conditions can be a barrier regardless of regardless of their socioeconomic status. So certain cognitive impairments can make it challenging to learn how to do dialysis at home. There may be a care partner that could be involved if this situation occurs. Patients may not have the ability to do connections between the catheter and their machine, or to lift the bags up to do dialysis if they have frailty. And so sometimes having the patients go to the home unit ahead of time to practice these things and see if they're able to do it or not is a better way to go about it, as opposed to assuming someone is too frail for dialysis. Also, having a care partner can be beneficial in this situation. We do have patients with vision and hearing loss that are able to do dialysis. They learn tricks to help them know how to do things. As they've done it longer and longer, they're very adept at doing it themselves. Patients that are not coming to their clinic visits or taking their medications or notifying their care team about concerns that they have may not be offered home dialysis, because the provider may be worried if they're not communicating when they're doing dialysis at home, that could become a very dangerous situation. In general, if I have a patient that I am taking care of where I have that concern, I will let them know that it is a concern, and that way we can work together to try to make changes and have that be an option in the future. There are some barriers that may be contraindications to doing dialysis, a certain type of dialysis. For example, peritoneal dialysis requires the catheter going into the abdomen. If somebody has had a lot of surgeries, it can impact um, the how well that membrane that is used for the dialysis is working. A lot of times we have to just try it and see if it works. Patients that have hernias that are not amenable to surgery, if you're putting dialysis fluid into the abdomen, that can cause that to worsen. So there are some times where just the anatomy plays a role in making one type of dialysis better than another. As far as informed decision making goes, I always tell my patients I'd rather talk to them about dialysis and have a plan and they never need it, than for them to need dialysis in the future and we haven't talked about their options. The reason I say this is because a lot of patients hear the word dialysis and they get understandably frightened. But if they're not willing to talk about it because of that fear, they may not get all of the education they need to make a good decision. There is a kidney failure risk equation that can be used. It is online, and plugging in labs from kidney clinic visits, such as the kidney filtration rate, how much protein the kidneys are spilling. It can be used to help predict the risk of kidney failure over the next 2 years and the next 5 years. It is a good tool, but it's not perfect. And there are times where that risk is very low, but something happens that causes the kidney function to decline much faster than could be predicted, such as infections or heart disease. And so it doesn't hurt to talk about the options and develop a plan in case that does happen. If the medical condition of the patient changes drastically at the time of needing dialysis, that plan can be changed. So there's no harm in at least talking about it ahead of time. And if the clinic visit is a good time to ask questions. However, there may be other ways to get education. So there's videos, there's websites. The home dialysis unit itself is a good resource. So I'll often ask my patients to go to the home unit and take a tour. They can talk to the nurse there and get a sense of what the equipment actually looks like, what they'd actually be doing, so that it's not so abstract as when we're just talking in clinic. And not all experiences of dialysis are the same. So you may know someone that's had a hard time with home dialysis, but that doesn't mean that you would have a hard time with home dialysis. Some patients hear an anecdote and it skews their idea of one type of dialysis or another. But it is good to keep an open mind. And if something is started but isn't working for the patient, that modality could be changed. So if someone decides they wanted to do dialysis at home and it's really not going well, or they have just too much burden of care and want to transition, that can happen. And there are patients that choose to do in-center dialysis even after getting all the education about home dialysis, and that might be the right decision for them. But if they decide, once they've started dialysis, that it is not what they were expecting and not what they want, they can bring up potential change to home later. So it's good to keep an open mind about all the different types of dialysis, as there can be medical changes that happen over time. For telemedicine, CMS allows us to do 2 quarterly visits. So 2 out of 3 visits can be done by telemedicine once the patient is stable on their dialysis regimen. So this can help to save time you don't have to come into the unit. Patients may have caretakers that can't come in but can be involved in the telemedicine visit. It can reduce the cost of having to come in to get gas, all of the things involved in travel. Some of my patients have to get a hotel room when they come, so that can be really helpful. And if there's something unexpected, the patient is too sick to come in, or they have a cold and don't want to spread that to anyone else, they could do a telemedicine visit. Barriers for doing telemedicine include a lack of internet access or a lack of usability, so not knowing how to set up the telemedicine. If somebody does have a language barrier and are not able to get translation services through telemedicine, that can be challenging. And then if someone is very ill from the dialysis standpoint, if they're having a lot of issues with extra fluid, it may be better to come in person so that you can have a full evaluation. If patients are, having to come in to have their lab draws and there's not a unit closer to home, then telemedicine may not be helpful, but it may give them more flexibility on the timing that they have to come in rather than being on the provider schedule. So generally, I just want everyone to take away, if they have kidney disease or a relative with kidney disease, to be sure to advocate for yourself and to know your options. And if you ask the provider, am I a candidate for home dialysis? If not, why not? What do I need to do to be a candidate? That can help to give time to prepare ahead of time. I always advise patients to think about this process again after starting dialysis once they know how it actually feels, because different people have different types of side effects from dialysis. And so once it's actually been experienced, it can change that decision making. All right, thank you.
Again, just like Dr. McDonald, you are reminding me of my journey and things that I had to consider and things that I had to do. And I feel from some of your questions that I think I was actually breaking some barriers back then, my nephrologist and I. that later came, to pass after I had sort of began my journey. Dr. Solani, I do have a I have a question for you. And this is actually from the audience. A member of our audience is interested in home dialysis, but is concerned about the space in their home and wanted to know how they should go about bringing that up to their team.
So it's fine to bring that up to the team just to let them know that that's a concern. And that is where a tour of the unit might be helpful to actually see what those supplies look like and how much space they're going to require. It's also helpful to ask them if they're able to accommodate more frequent shipments. So instead of every month, sending every 2 weeks so that there's not so much at one time.
Okay. Another question is, you had mentioned telemedicine as an option, and I think that seems very interesting. Is that a program that's specific to your clinic, or is that something that is being implemented on a wider scale in other institutions?
That is something that is available nationally. Most of the dialysis organizations will have the capacity to do telemedicine built into their electronic health record. So not all units may be taking advantage of that, but it's worth asking about because most will have that as an option.
Okay. As you were going over the different modalities, you had, and I actually have experienced this. I chose my modalities based on where I was in my life and what I could do. And you had mentioned modalities changing over time. Can you share why this may happen? And would it be in relation to patient's choice to change modalities or medical advancements in the home dialysis space?
So that's a great question. I think the answer is it can be either or. Sometimes it's the patient's choice to change because of their lifestyle or the burden of care. Sometimes patients have to change because, for example, if they're on peritoneal dialysis and they develop an infection that's severe enough that the catheter needs to come out, they may not be able to do peritoneal dialysis temporarily, and they may do hemodialysis until they are able to get another catheter placed. Sometimes patients of mine go from home to in-center. We think it's going to be temporary, but it actually works better for their lifestyle. So there are sometimes where it's patient choice, sometimes where it's medical necessity. And as far as advances in the dialysis field, I think every time there's a new machine, new technology, it's good to reassess if there's going to be a benefit of changing.
You talked about your specific session was about the barriers and so forth that potentially exist. Barriers, in the word barrier in itself carries a negative connotation. How do we help patients and providers shift their mindset of seeing barriers as hurdles to navigate as opposed to a block to receiving care?
So I think anytime you're told that something is a barrier to transplant or to home dialysis or any part of your medical care, it's good to think about or even ask, what are the things that I need to do so that that's no longer a barrier? And sometimes there's not something that can be done, but a lot of times at least knowing what the steps are ahead of time. So sometimes, for example, with transplant patients are not able to get one due to age, and there's not anything that can be done with that. But if they're declined because of their weight, then letting them know exactly what their target is, and again, once they meet that target, once they've kind of climbed those hurdles, making sure that that isn't just off the table because it was, a year ago or 2 years ago.
Okay.
So providers also need to keep that in mind.
All right. Thank you. Both of you had alluded to like the care partner. Is a care partner absolutely required for one to do home dialysis?
No, I have a lot of patients that do peritoneal dialysis by themselves, and I have a few patients that are doing home hemodialysis by themselves. Um, if they have a care partner, it can be really helpful, even if that person is there more for emotional support than anything else. But a lot of times, having someone who can also know what the process is, so that if someone is too sick to do it themselves, it can be beneficial, but it's not mandatory.
Okay. And I'm kind of going back to one of Dr. McDonald reference. We know that rents are high, or utilities are high too. So what impact to the electric bill do you think home dialysis would incur with regards to like an electric bill?
Yeah, it can definitely increase those utility costs, particularly for water if it's hemodialysis and electricity. The electric bills, sometimes the insurance will have some coverage. That's not a guarantee by any means, but there are times that we'll see that they can show the difference between their bills before and after and get some sort of assistance either from the practice or through their insurance.
Okay, thank you. So as we approach, we have several more minutes remaining. I kind of wanted to ask, there were several other questions that I would like to ask you all. And Dr. McDonald in particular, you had done such a great job of talking about vascular access and what types there are, and the specific type of vascular access that is preferred. And I don't think that can be repeated enough. So I was wondering if you could just cover that one more time.
There we go. Okay, now I'm heard. Certainly, I'll be glad to cover that. As I mentioned, we like to have a fistula, which is the connection between the artery and the vein. We like it to be mature, so it may be several months before the patient starts dialysis that the fistula is inserted. As I mentioned, it's done under day surgery. And once it's done successfully, it can almost look like a big worm underneath the skin. I've had a couple patients that are very vain that don't like the appearance of the fistula. Now, in some cases, particularly petite people with small vessels, fistulas aren't successful. And we have patients that have perm caths. We all know that perm caths will increase your danger of infection. Sometimes it's unavoidable, but we do have some home programs that will take patients with perm caths. When it comes to peritoneal dialysis, the catheter can be inserted under day surgery on either side of the belly button, and we like it to heal over 4 to 6 weeks. We can use it sooner than that with an urgent start kind of protocol.
Okay. So I have a question for both of you. Either feel free to chime in, either one. How are candidates screened for home dialysis?
I know that generally, for instance, we have in our practice options. And so there's a 6-module class that patients can attend. It's a video and then one-on-one with a doctor. We talk about dialysis options and encourage the patient to make a decision when they're close to starting dialysis.
Mhm.
So they've heard a lot about it. As Dr. Solani mentioned, the education process is important. I have some patients on my hemo shift that will mention this to them. I think the biggest contraindication is, as mentioned by Dr. Solani, non-adherence or non-compliance. If you have a patient that doesn't show up, they're not going to show up for home hemodialysis either, or either home peritoneal dialysis.
Mhm. That's a good point. Dr. Solani, did you have any comment?
I agree with everything Dr. McDonald said. I think that in general, I'll offer home dialysis to all of my patients, and we can try it. If it's not working, we can always change modality later. However, there are times where I'll tell them, I think we need to take care of the XYZ first, because I want them to have the best shot of success if they are going to try it.
So another question that I have for both is, are there any instances, and you've covered this, but again, I think it can't help, it should be repeated. Are there any instances where someone may be denied home dialysis?
Well, I'll say, it's happened to me several times. The patients just didn't have a home, and it's very sad. But you have people that are technically homeless. I have patients who live in like these storage units, public storage. Um, so that really is a big contraindication. You got to have a home.
Dr. Solani?
Absolutely. Um, Again, there may be some times anatomical barriers if someone's not able to have peritoneal dialysis. And home hemodialysis it can use either vascular access if someone has a fistula but they're not able to cannulate it themselves and they don't have a care partner. That could potentially be a barrier. So there are times where it's not appropriate, but it would really require a talk between the nephrologist and the patient.
All right. Well, I want to thank you both. I mean, there are so many more questions that I want to ask and I would love to ask, but we are coming close to the end of our session now. And I really, really wanted to thank you. I wish we could be in person so that I could thank you personally. But again, it's been a great session and I've enjoyed hearing from both of you. To everyone who is participating on our call today, I would like to thank you as well. Encourage you once again to put your questions in the chat, and we will get back to you as quick as we can. Again, thank you to our amazing panelists today for session. Thank you to our amazing panelists for today's session. Self-canalization, moving from intimidation to power. Excuse me. Sorry, misread something. We will be moving into additional sessions as we continue with Kidney Action Week. We encourage you to continue to follow along. We have one more day remaining for everyone to participate. Please visit the American Kidney Fund website at kidneyfund.org and register for sessions for the remaining sessions. We hope you found this session to be insightful and educational. And always think kidney health. It benefits you.
Thank you.